Well, good morning to everybody. Thank you for coming. We welcome you here to the Shiley Eye Center. This is the hopefully the first of many seminars that we hope to have here. My name is Don Kikawa. I'll be moderating the first part of the seminar. The seminar is entitled Graves' Eye Disease, A Patient's Perspective. And today we really want to hear from you. You're the ones that have taught us the most about this disease, who've dealt with the devastating complications, how it's affected your lives. So the format may be a little different than what you're used to attending in a medical symposium. This is co-sponsored by the UCSD Department of Ophthalmology and the Graves' Disease and Thyroid Foundation. We're especially thankful for the support from Steve and Kathleen Flynn, as well as Kimberly Doris, who has helped organize the seminar. The format is going to be a series of focused talks by Dr. Korn, who's on faculty here, Dr. Granite, and myself will be speaking on specific topics of Graves' eye disease. And then the format is really going to shift to a patient-centered discussion. We've had several very generous patients who have volunteered their time. They volunteered to be helpful in sharing their information of how this disease has affected them and what they've gone through and their treatments. So we really could not have this seminar without the support of all of you and for your help in educating not only us, but other patients. So at this time, I'm going to introduce Dr. Bobby Korn, who will be speaking on the topic of Graves' disease ophthalmic manifestations.
Thank you, Don. So today, of course, I'll be talking about what you're living with every day. So, I'm going to cover as much as I can, but really, I want this to be as interactive when we have the interactive session as possible. And tell us, you're our teachers, okay? I always start off with this slide to really thank you. We wouldn't be here without you, right? It's what we've learned over the years of talking to our patients, going through the trials and the tribulation of the disease, how it's affected your lives, how it's affected your jobs, your relationships, all facets of your life. So, if it weren't for you, we wouldn't be here. So thank you very much. And again, I want to reiterate Don's acknowledgments to the Graves' Disease Foundation, to the Flynns, to Kim Doros and Karen for organizing this great event. So let's start at the beginning here. And what is Graves' disease? Well, of course, it's a moot point. Everyone is living with this. But one of the first things that, when patients come to see us in the clinic, in our thyroid eye clinic, is that we would like to educate them on what the actual condition is. We not only treat the medical and surgical aspects of the disease, but our roles as physicians is also to educate. And often, patients come in with the conception that I have Graves' disease. My thyroid is enlarged in the lower right-hand corner there. If I take my thyroid out, or if I treat it surgically, that'll get rid of my eye disease, correct? And that's one of the first misconceptions that we educate our patients. And in fact, it's really the immune system that is causing the disease. This is called thyroid eye disease, and the lay public and the patients who are not experiencing this condition think that it's actually the thyroid that's attacking the eyes. But it's actually the immune system, the very part of our body that fends off infections, has somehow miscommunicated in its communication with the different cells and is now attacking both the thyroid and the eye. Now, oftentimes, these two conditions work in parallel, but they may not. Your thyroid may develop a goiter years earlier or years later before your eye disease and symptoms begin. So the first thing is that the eye and the orbital symptoms do not correlate with the thyroid directly in a sort of a one-to-one relationship. It's the immune system that is the common component here. So how does it affect you? Well, many, many different ways. Burning, redness. How many patients in here wake up in the morning with tearing eyes, red all the time? Right? Pretty much everybody, right? A lot of my patients have tissues in their pocket that are continuously dabbing their eyes. Double vision. Who's got double vision in here? You know what that's like, how hard it is to live with. My wife says, I never want double vision because I don't want to see two of you, okay? Eyes bulging. That's probably, one of the most telltale signs that, patients have. I hear so many stories of grandparents coming to us and telling them that our grandkids don't want to talk to us or they run away from us because we look scary and we want to do everything we can to just to avoid them. We wear dark shades, so these are things that you live with and we hear about. Social withdrawal. We often ask our patients, can you show us some pictures of what how bad the condition was like? And more often than not, we say, well, we really don't have pictures. And at first we thought, why wouldn't you have pictures? And then we put ourselves in that position. Would you want to take a picture of yourself when the disease is really bad? And so oftentimes we'll get pictures in groups that patients will bring in. But social withdrawal, this is a huge one, both from your families or social networks with your friends. This leads to depression. Our group actually published over 10 years ago that this condition, thyroid eye disease, affects you psychologically to the same degree as if you were diagnosed with cancer. At the workplace, believe it or not, if you have a picture of a patient who's an identical patient, you put them in a computer, do Photoshop, and make one eye larger, deviates, there will be subtle, subconscious discrimination against that person, even though it's the same person. So this affects us in all walks of life. Here's a good example, the proptosis and bulging of our eyes. You can see that not only are the eyes open, but if you look on the right side, there's all that redness that you see. And associated with that redness is all this tearing, and it's this constant vicious cycle where your eyes are exposed, they're pushed out, they're watering, they're irritated. Double vision, all right? You'll see a lot of pictures today, and some of these pictures of yourself, or of your colleagues, your friends, and you'll really be able to appreciate how this disease really impacts your lives. Of course, this very pleasant patient of ours, who actually is in the front row somewhere, has pretty bad double vision. So those of you who don't have double vision, this is what you see here when you're driving on the road. Okay? Those of you with double vision, this is what you see. Okay? And this is pretty hard to navigate, on a road here with traffic like this. And, what do our patients often do? They often cover their eyes up, okay? Just one of the eyes to see. Obviously, you don't want to cover up both eyes because, that'll put us at significant risk. Another manifestation of thyroid eye disease is eyelid retraction. You can get combinations of this. The eye can bulge, it can be misaligned, it can be retracted. This patient here simply had the eyelid that was elevated on that side. What can also happen with your eyes? How many patients wake up in the morning with your eyes irritated, burning on fire? Okay. Why is that? Often because this disease prevents you from closing your eyes. Okay? And this is a patient here who's doing the best you can to close her eyes. And during the day, you're blinking. Your eyes are being moisturized, but at night, they dry out and evaporate. So we always tell our patients, put moisturizing drops, ointments in your eyes to keep them nice and moist. Optic neuropathy, what is this? Well, in a rare set of patients, probably less than 5 to 10%, the disease can be so bad where the muscles get big and or the eye gets pushed out so much that it squeezes on the cable that communicates the eyeball to the brain, and you begin to lose vision in one or both eyes, okay? And that's a clear example here on the left side here. So what can we do? Oftentimes in our clinic, when we're having this discussion with our patients, we're showing all these pictures, we're educating, and then we have to say, we need you to wait. And that's probably the most frustrating thing that we all do, because we want to intervene and treat as soon as we can, but we can't. Why? Because the disease has a course. It has a time course where it actually gets worse initially on the left side, where it deteriorates. Eyes open up more, they push out more, the misalignment worsens, to a point where it stabilizes and then actually improves slightly. We want to intervene on the right-hand side at the improvement stage. We don't want to intervene too early. Why? We don't want to hit a moving target. Okay? What's our overall approach? I'm going to briefly hit on the medical management, and Dr. Granite and Cacao will talk about the surgical management later. In general, we go very conservative first. Medical management first. If you have double vision, we can give you prisms or do botulinum toxin or Botox. And then we begin the steps of the surgical rehabilitation. Now, we violate our rules rarely, okay? And number 3, optic neuropathy, that picture of the patient who is losing vision, only in those cases will we intervene a little sooner. Conservative management, I'm sure many of you in this room have tried every drop that's on the market at CVS, Walmart, Costco. Keeping our eyes as moist as they can is the best management you can do initially. Now, how about steroids? I'm sure everyone's read about steroids, right? If you've come through our clinic, you'll often find that we don't use steroids a lot. And a lot of our patients come in saying, oh, I've read all these great things about steroids. I should be on steroids. It controls my symptoms. It makes my disease better. In Europe, there's a large consortium similar to the Graves' Disease Foundation, composed of endocrinologists and ophthalmologists called UGOGO. And they've published multiple studies showing that use of steroids does improve symptoms. But the question that we always have is, does it actually alter disease course? Does it make a difference at the end of the day when the disease burns out? We know that steroids are not without risks. Now, these aren't the steroids that make your muscles big like Arnold Schwarzenegger. These are the steroids that control the inflammatory system, but the risks are diabetes, high blood pressure, joint damage, mood alterations, weight gain, and there's even cases of liver dysfunction and even death from steroids. So we're very cautious. When do we use steroids in our thyroid eye center here? If we have to, we use it locally. We prefer to give it in injections around the eye so that it works in the area that we need to and it doesn't absorb in the body as well. And if a patient has optic neuropathy where the vision is affected. And we use this as a temporizing measure until we can go in and have surgery. Now, who's taking supplements for their thyroid eye disease? Anybody in here? If you go on the internet, you will find hundreds of supplements out there, all right? Now, do they work? You know, the answer is we don't know. They probably have some effect, but you know, in the medical realm, we like to go on placebo-controlled trials, evidence-based medicine, and so we like to look at very, very strict, definitive scientific studies comparing placebo, where we don't use the medication, and the supplement, all right? But all these have been listed, and I didn't have room on the slide to list them all, but the one I do want to mention to you is selenium. Now, has everybody heard of selenium here? This was a study that was published in the New England Journal of Medicine, I think about a year ago. And what they looked at was, in Europe, if you supplemented patients with selenium, what happens to your eye symptoms? And what they found that when they gave 100 micrograms dose twice daily, and at 6 months, symptoms of our patients got better, all right? So there are a couple caveats though, all right? This was done in an area where selenium was deficient, so it actually could just be replacing a mineral that was already deficient. The other potential caveat is that there are some question that high doses of selenium can actually lead to higher incidences of type 2 diabetes. And then finally, there was one potential report that skin cancers could actually be higher recurrence if you had them primarily. So, you know, take everything with a grain of salt literally, all right? Now, is there anything I can do now? If you're a smoker, I'm not going to ask you to raise your hand here, okay? But please stop smoking. That is the one thing that we know can make a difference. In our patients, the ones who often have the most severe disease are the smokers who are exposed to primary or secondhand smoke. Consider selenium supplementation. Do your research, you know, read the papers, and more importantly, use common sense. Good diet, exercise, keep your follow-ups with your endocrinologist and your ophthalmologist, all right? And then finally, there is hope, okay? I think Dr. Grant is going to talk next. He's going to give you his side of the double vision and what you can do and what you can expect. And he's going to show you some fabulous pictures of patients before and after to see all the magic that we can do here. Thank you very much.
Thank you, Dr. Korn. I first met Dr. Granite about 20 years ago when we both joined the faculty here at UCSD, and we've aged a lot since then. But Dr. Granite and I have treated thyroid eye disease for, you know, almost 20 years, and we started a clinic here in 1997. So we have about a combined experience of about 17 years of treating it here. He's been a great colleague, and he's very knowledgeable, and you know, I think he has really helped to advance some of the surgical procedures with strabismus. So, Dr. Granite.
Thanks, Dr. Kya. It's really amazing to stand here and think about the time that's gone by. And some of what we do, we take for granted when we have all the doctors standing in a room talking to patients at the same time. But you have taught us that that doesn't happen everywhere. To us, it became natural. I would, when we first got here, I'd run down the hall and go, Don, we have a patient coming. And we go back and forth and running to each other, and that got crazy. Or sending you back and forth to different people got crazy. And so we learned from you that it was helpful to put all of us in the room together. And a lot of what I'm going to talk about today is what we've learned from you. In scientific talks these days, we give disclosures. I have nothing to declare. Yeah. This is the eye, and it moves. It moves up and down, side to side, and it spins. So it has what we call 3 degrees of freedom. 3 ways it moves. But we have 2 of them. And you can imagine how difficult it is to get these 2 eyes to move in exactly the same place so that they see the same image. Dr. Korn pointed out what double vision looks like. And you can imagine, just on a day-to-day basis for someone who has no eye problem, how amazing it is that the 2 eyes work together. There are 3 nerves on each side of your brain that control the movement of these 6 muscles. And as Doctors Cacao and Korn would tell you, 7 if you include the eyelid. You saw when you look up, the eyelid has to go up. When you look down, the eyelid has to go down. All of that coordination is incredibly complicated normally. Now let's take a disease that changes the muscles of the eye by, as Dr. Korn pointed out, the changes that go on throughout the body. The neck gets bigger, you get goiter. You effectively get goiter of the eyes, the way they swell forward. The fat swells, the muscle swells, and the muscles actually change by the infiltration of all this material into them. They start to change their shape. Instead of looking normal and thin, they get what we call fusiform, where they get wide and then thin again. How on earth do we expect those muscles to behave normally? We see in some people that you end up with muscles that, over here, this is a CAT scan. Those muscles actually look okay, but the fat has pushed the eye forward. That's a completely different scenario than type 2, where the muscles have gotten gigantic. That's an inner muscle, and it's now 4 or 5, 6 times the size it used to be. And those people are both called Graves' ophthalmopathy, or Graves' disease, in one giant basket, with misalignment of the eyes, proptosis, and we're supposed to figure out one size fits all, the same surgery for all, the same response for all. It doesn't even make common sense, and it doesn't make surgical sense. So it's not a surprise that people come into us frustrated by waiting. It gives new meaning to the word patients, doesn't it? I mean, having to sit there and wait and wait. You come to see experts, quote unquote, in thyroid eye disease who look at you and say, wow, we take all this information, we get all this stuff, and then we say, we have nothing to offer you. We have to wait for the disease to hit the end of its curve. How frustrating that is to wait. The good news is the light at the end of the tunnel is not an oncoming train. There is hope, and there are things that we can help you with. There are so many things that we have learned along the way. So many publications that we have done at international meetings. Drs. Cacao, Korn, and I have spoken all over the world about thyroid disease. What we do in this little corner of the planet here in San Diego, the left-hand bottom side of the United States, has actually had these impact around the world. And that means the impact that you have had in teaching us goes out. So this has been a very impressive thing that we've been able to put together where you have taught us. But I would say the most important thing that we have learned is the psychological impact of this disease. When we first did it, I bet Dr. Cacao $20 that we would find out that double vision was worse than disfigurement or change in your appearance when we looked at the anxiety and depression that was caused by this disease. And I lost. I thought, how on earth could function fall behind appearance? And one of the patients looked at me and said, Dr. Granite, I can get rid of the double vision. It's gone, but it can't change the way I look. The way I look is affecting how I feel and how people react to me. We've had days where we'll see 25 patients and 23 will cry. You can't help but notice that. You've taught us the value of that, and we have spread your word to doctors around the world, telling them, don't ignore what's happening to the patient. This impact, it's almost hard to put in words what it does to you. And so The slide that Dr. Korn put up about hope becomes very important. But the idea of not ignoring the psychological burden becomes very important. The 5-step plan you heard about means that we have to wait, that we try and sort of stall while we're waiting to get to the part that we really want to do, which is help you. And that means that we want to take you from perhaps here to there, to straighten the eyes out. And then eventually Dr. Kikawa fixed his lids on the end. Somewhere between 30 to 50% of people with dysthyroid problems end up with eye motility problems, the way their eyes move. Sometimes it's transient. Sometimes it gets better. Sometimes it doesn't. And then we're left with people who have misalignment of the eyes. I told you there are 6 muscles that move the eyes: paired up and down, paired side to side, paired that spin. Well, there's actually a pattern to how those muscles get involved. The inferior muscle and the inner muscle are the first 2 to get involved. So in thyroid disease, some of the things that happen right away are that you can't lift your eyes up and you become cross-eyed. So if only the bottom muscles get involved and you are blessed to get them involved equally, you start to hold your head more and more and more like this because you can't lift your eyes up. So you end up walking around with what we call a chin up position. But if your inner muscles on each eye get involved, you end up cross-eyed. And there is no way to turn your head to fix that. So then we have the superior muscles and the other muscles get involved. Would you believe we still don't know why? We don't know why those muscles become involved in that order. There is some research that has started to look at, are there different components of each muscle that actually help the reason that help explain the reason why this occurs? But we're still not sure. So what do we do? Well, one treatment is just to cover the eye. That's failure for somebody like me, covering an eye. It gets rid of the double vision, but it's not the solution that we want. Then we have prisms, and those of you remember from physics, prisms take light, as you can see in the picture, bend it. So the prism actually takes the light that's coming in and moves it to where your eye is. And that's how it works. And if you're not sure if anyone can actually function with that, that is former Secretary of State Clinton. And she ended up with double vision, and you may see what you have had on your glasses, these fine little lines. Those are prisms that have been placed on her glasses. She fell and hit her head and then had double vision. She actually testified in front of Congress with those glasses on. And this is a high-resolution photograph that somebody astutely took because they noticed something was wrong with her glasses. So she had to wear prisms. They work really, really well when the amount your eye is offline is the same everywhere you look. But in thyroid disease, that's often not the case. That when you look left and right and up and down, the amount your eyes are off changes. But the prism doesn't change. It doesn't know that when you're looking to the left, you need a different prism than when you look to the right. So the prism often fails in that scenario, or at the very least, it gives you modest help. It makes it very hard to drive that way. So then we start talking about more invasive treatment like Botox. It's funny to talk about Botox, right? Botox gets rid of wrinkles. Well, this is one of those moments where we get to claim some fame as eye muscle surgeons. The first approved use of Botox medically was for misalignment of the eyes. Dr. Alan Scott, who's up in San Francisco, one of the great pioneers in medicine, figured out they could use this toxin in very small amounts to relax a muscle and straighten the eyes out. And that's the first approval by the FDA for the use of Botox. So we can use that prior to stability. Then we have surgery. And then when finally stable, we can operate. So does it work? Does Botox work? Well, we've learned a lot. Because Dr. Kikawa and I were standing in the room together, we would talk about what else we could do. And we came up with the ideas that the time that he did decompression, inject the Botox because he's looking at the muscles right then and there. That only happened because we were together, talking with you, talking together in a group where everyone had input into the care. And we were able to do that, and it worked. It actually makes a difference. Look, these muscles are gigantic. They shouldn't be much bigger than the optic nerve, and look how big they are. So there's the inner muscle, the upper muscle, the lower muscle, the outer muscle. They're enormous. So at the same time as decompression, Dr. Kikawa would inject Botox. He presented this at the ASOPRS, which is the Oculoplastic Society, of which he humbly would never tell you this. He is now president of the North American Society for Oculoplastic Surgeons. We're very proud of his accomplishment. But we showed and he demonstrated that it worked, that it straightened the eyes out, and it made a big difference. Nobody got worse, and many people were helped. In fact, here's someone who had only a decompression and a Botox injection. You may be able to see that this eye is lower than the other eye, and afterwards, they were equal. So here I was making myself obsolete by having Dr. Kikawa fix strabismus, and I ended up having no actual need. I went up, great. So, but it was wonderful to see because this was born out of us all being in the room together. It's the only way that happened. So does it work when we use it in the office? When I get to actually do the strabismus, we presented this at the pediatric ophthalmology meetings, and we were able to take people with smaller deviations, and a third of them prevent them from having surgery by the use of Botox. Now, it's not supposed to work because in thyroid disease, the muscle turns to scar as well as muscle. And the scar is not supposed to respond to Botox. Yet it does if you get it at the right time and a small enough deviation. And this came because a patient of mine said to me, "Can't you do anything? Isn't there something that you can do?" Every time she saw me. I mean, over and over. And I kept going, "No, I have nothing. I'm sorry." And she goes, "Come on, you're smart. I'm willing to try anything. I can't live like this." And so I looked at her and I said, "Never tried it before. Once or twice it's been tried." I spoke to Dr. Scott up in San Francisco. He had tried it a couple of times. And from her insistence and education, and we spent hours together, we tried it. And son of a gun, it worked. And that led us to go forward. So together, we marched forward and we were able to make a difference. Now, sometimes things don't always work that well. As Dr. Korn talked about it, we like science. You take these gigantic muscles and you shift the location of the eye and you run the possibility of squeezing the optic nerve. And in all the Botox people, we've had a couple that happened to, and we had to be prepared for that. Now we know, and we've taught others about when to use it and when not. We also found out that some people's eye pressure goes up when they have thyroid disease. The eye's being pushed forward. It's got these big muscles squeezing it. It's a balloon with water in it. You squeeze it, the pressure goes up. Well, that's one form of the way the eye gets damaged in a disease called glaucoma. When the pressure's too high for that eye, it can't tolerate it. What we demonstrated is that when you do the Botox injection, the pressure in the eye goes down. And we also showed that when you do surgery, the pressure in the eye goes down. We've had people scheduled for glaucoma surgery that Dr. Kikawa and Korn did decompression surgery on, I did muscle surgery on, and the glaucoma, in quotes, disappeared. Because the pressure really was from the pressure on the eyes, from the disease called Graves' disease, not from glaucoma. So how do we inject? I was asked to be on the doctors, which is the little in the corner there, and we showed this live on the doctors. It's not scary. You can even hear our patient talking while we did it.
Okay.
And grab the eye. If you're queasy, don't look. Sorry. Some of you have had this, so this is what it looks like from the outside. Little needle slides right into the muscle. And you can actually use with the wire, like EKG, you get an electromyogram.
Dr. Hassan's going to move you over in the same plane you're in.
In a second,
Keep going.
you hear the static.
Keep going.
That background static is actually the muscle making its sound. There it is.
That noise means we're in the muscle.
Ah.
And then we inject the Botox. It takes about 2-3 minutes in the
Keep looking
office.
at the finger.
We've spent more time talking about it than it actually takes to do it. So it's pretty amazing that we're able to do it, and she talks the way through it. Careful planning always matters. We never want to be in this scenario where we built our house behind a telephone pole. And in thyroid disease, there are special things that we've learned, that you have these tight muscles. Tightening them doesn't help, loosening them does. So we have to loosen them. My fellows and I have come up with this information sheet. We collect all the data, we do calculations, we plan out how we want to put this together and what kind of surgery that we want to do. It used to be taught that you could only help someone looking straight ahead. That was the best you could do. My patients are not happy with that. You are not happy with that. So I have to stand there after we're done, look at you, look at Dr. Kikawa and Dr. Korn, and they're all going, "Can't you do better? Come on, you can do it." And so we over 20 years of having to live through that, we've tried to come up with a better way. And our goal now is that on an average day, doing normal things, you don't have double vision. If you look in a funny position like this, maybe you'll get double vision. If you look all the way to the side, maybe you get double vision. But wouldn't it look funny if I stood here lecturing to you and talking, and I went like this? Hi, I'm Dr. Grant. No one ever does that. We all turn and face the people we're looking at. We look about 10 or 15 degrees, and then we move our head. So if we can get that range, we can make you function normally. It's not the same as you were before. It's not. But it's pretty darn good, and it can get you to forget about your eyes on a daily basis, which wouldn't that be nice? Forget about your eyes. So we wait until you're stable, and then we do the surgery that has to be, and we have a whole bunch of stuff that we do. We have all these techniques that we've developed that we teach to help people. We've developed different tools that didn't exist before to try and make the surgery better because the tissue in Graves' disease is different. We have special hooks that we use to grab the muscles. We have music that we play in the operating room. We have techniques that we developed here, and this is my partner, Dr. Robbins, where we figured out how to delay at the end of the surgery. Instead of tying a permanent knot to hold the muscle, we put a slip knot there. And 5 days later, I can look, and if you're not straight where we want you, because your muscles may be different thickness, they may have different scarring, they may not be as big, they may move differently than someone else. I need to have a get-out-of-jail-free card. I can slide that muscle and move it if I have to, right in the office. 9 out of 10 people don't need that. But for that 1 out of 10, boy, it's life-changing to be able to fix someone. Don't look if you don't like surgery, but here's a muscle. We cut it, we sew it, and we tuck all the stitches underneath. That outer white covering of the eye is just a covering. It's not the eye. It's like my shirt. You can lift it and size it, and the muscles are right underneath it. The advantages of that delay are all the obvious. Most importantly, it gives us a second chance at being able to identify how straight someone's eye is and get it straight. There are new techniques that we've been using that are actually old. We scour the medical literature. This technique is from 1845, where you make a small little hole in a muscle. And those little vertical deviations that sometimes people with Graves' disease get, we can get rid of instead of locking them into prism glasses, which used to be the standard. We want to get rid of that. Southern California, nobody wants to wear glasses. So if we can get rid of that, that makes a big difference. And we've reported this at our national meetings. One of the things that comes from Dr. Kikawa and Dr. Corder and I working together is we demonstrated that once I release these tethers that hold the eye might stiff forward. And so the great surgery that they've done to move the eye backwards can change. And we reported that to teach other doctors to be prepared for the change in that. We've shown that glasses needs can change after the eye muscle surgery. Of course it does. The muscles are pushing down on the eye. They're changing the shape of the eye. We've shown that one of the reasons why the lid has to come last is here's someone whose lids are pulled back. And all I did was operate on the eye muscles. And now the lids have come together. Imagine those bottom muscles are really tight and the patient's trying to lift their eyes up. Well, the lids go with the eyes. So all that effort trying to lift the muscles of the eyes up and the eyelids go whoop, and they go up. When I released those lower muscles, the eyelids came down. So Dr. Corn and Cacao can't operate on your eyelids until I'm done because they may shift and they may change. We've pioneered and published when you can do those two together and when you can't, because we're together all the time talking about this. Now this is new, and this is something that I think is really important that also came out of us being together. Here's somebody that Dr. Kikawa operated on look how far back he moved that eye. And this is what it looks like on a CAT scan. If you look carefully, this is the bone of the orbit, and the eye is actually in front of the bones of the orbit. When they're done, it's about in the middle where it should be. Here's another picture, similarly. It's in front of the orbit, and when they're done, they're back where they should be. Imagine trying to make eye muscles move normally when the muscles are stretched out all the way like this. How could they possibly ever move? But the standard wasn't to do decompressions unless it was vision threatening. So all my colleagues were trying to operate in situations where the muscles were out like this. So for 20 years, I'm with Dr. Kikawa and now Dr. Korn, and they're doing these incredible decompressions, and we're getting these great results in strabismus, and I'm thinking I actually know what I'm doing, and I'm really good at this, and we've developed all these new techniques. But what may really be happening is they're giving me eye muscles that are not like this anymore, but they're like this. And now there's room to move. So these incredible decompressions that they're doing have now given me the room to make an eye not just be straight ahead, but but to be able to look down to read, and maybe look up a little bit to look at your rearview mirror in the car. So the combination of us working together has delivered better outcomes. That great decompression that they deliver to me and to you allows us to get it so that we can get someone together. The integrated care of a thyroid center where all of us are working together is the difference between success and not success. There are lots of challenges. Somebody might recognize themselves here again. Why does one eye happen and not both eyes in an autoimmune disease? If anybody knows the answer, please raise your hand, grab us, tell us, because we don't understand that. And in fact, we have people who after one eye has been settled, years go by, the other eye kicks in. And we don't understand that either. So we're still trying to figure that out. We don't understand why that happens. We don't understand what predicts it. But I can tell you this, understanding this disease, what you have taught us, and hopefully what we're helping teach you, goes back to what Warren Buffett said. The happiest people do not necessarily have the best things. They appreciate the things they have. And I think Graves' disease does that to you. I think it makes you appreciate what it's like to have a normal appearance. It makes you appreciate what it's like to have eyelids that close and eyes that are properly moist. It makes you appreciate what it's like that your two eyes work together. The gifts that everybody else takes for granted, you now appreciate. So with that, I'm going to end and turn the podium over to Dr. Kikawa, who's going to discuss with you orbital and eyelid changes that take place in Graves. And thank you for your time, attention, and we'll have lots more to talk about in just a couple of minutes.
Okay, thank you. Thank you, Dr. Granite. I always learn things when I hear Dr. Granite speak. So he's a great speaker, great communicator, and he certainly has done a lot to help many patients with this disease and actually advance the science, which is important. So I'm going to speak briefly about decompression because I think we're all anxious to hear what you all have to say. So my talk is going to be more general concepts, and I think it's something that you all can get more information about. We're going to have some time at the end of the seminar to talk. But you know, other than preventing the disease, this is the first talking point I have. Other than preventing the disease, which unfortunately right now there's no magic bullet that will do that. There are studies going on. We have no other way to return patients to their pre-disease state. Surgery is the best option. It may not be for every patient, but it's the only option we have to try and get you back to how you were before. Modern decompression has evolved over 100 years. And initially, early on, 50 years ago, I probably wouldn't want to have the surgery if I was a patient back then. But we've evolved the technique now to where it's safe, it's effective, and it can be done either as an outpatient, if you have one eye done, or if you want both eyes done. Some patients travel from far distances, they can't take time off work. We do both sides at the same time, and we keep you overnight in the hospital. It's very effective in relieving proptosis, which is the bulging of the eye, as well as the deep pressure and pain that people feel behind their eyes. The traditional indications are optic neuropathy. Dr. Korn showed the dimming of vision. That's where the pressure builds up so far that we can't relieve the pressure any other way. Sometimes the eye sticks out so far in the eye socket that patients can't close their eyes. They develop exposure. That's another indication. Disfigurement. And this is something that we'd be happy to discuss on the panel discussion. You don't look like yourself anymore. And that's probably one of the main indications that we do the surgery. And then preparation for strabismus surgery, where the eye is just pushed out and so far down, we have to bring the eye in before we fix the muscle straightening. Many of our patients who are on the panel here have shared photos. And you know, this is something that's part of their personal life, and they've been gracious enough to allow you to see what they've gone through. This is one of our panelists, Jerry. You'll meet her later on today. This has evolved over about a period of 2 years. Sometimes the disease progression can be quite rapid. This is Jerry when she was before the disease, and then over a period of 2 years, it really progressed to where she was when she decided to do something. Our hope is that, you know, as surgeons and doctors that take care of the disease, that sometimes, and you know, in the best of circumstances, we can restore the pre-disease state. That should be our goal. That should be the gold standard of what we hope for as surgeons and doctors who care, to try and take you back to where before this started. And this is Jerry's photo that I showed you where she was at the height of her problem. And here she is when she's after all of her rehabilitative changes and surgery. She went through a lot to get there. And we'll hear from her later, her experiences. And you know, I'd like to ask Jerry if she would do it again. Point number two, we have to tailor the amount that we can do as surgeons to meet the disease process. It's not an all or nothing operation. We can tailor this to how much your eye is bulging. If it's not bulging that much, obviously we don't want to take it too far into where you're sunken in. So we have guidelines of how much surgery we do. And this is kind of the table that we refer to when we decide how much we want to bring the eye in. And there are different types of combinations of surgery. We're not going to get into the details. I'm not going to show surgery like Dr. Granite showed, but you know, just as a skeletal diagrammatic way of understanding this, if we want to get the eye in 2 millimeters, we do this operation. If we want to get it in the most that we can, then we do this operation. So there are ways that we can try to predict how much to get the eye in. This is a slide that Dr. Granite showed. Where do we perform the surgery? A lot of this depends on the type of disease that you have. There can be more muscle involvement, more fat involvement. We target the areas based on the scan. This is the bone that's surrounding the eye socket called the orbit. And we do use very fine instruments to sculpt and polish the bone to expand the space. That's part of the surgery. We also take fat out. These are just some typical examples of patients that have had surgery. This is a patient who had fat decompression. So this was not any bony enlargement. This was just removal of some of the fat, the puffiness. And then this is after eyelid retraction surgery where the upper eyelids were lowered. This is an example of a patient who had a lateral wall decompression, and we can bring this up later on during the physician panel. What's a lateral wall decompression, what's a medial wall decompression, but there are different walls of the orbit we target. The eye sits in a box that's bounded by 2 walls on the side, a floor, and a roof. So this is an example of the lateral walls. So if you look at this green shaded area of the eye socket, this is the area we're targeting on. And this is what's called a lateral wall decompression where we take some fat out. In addition, this is a 2-wall decompression. So this is, if you've ever heard the term balanced decompression, where if you consider the eye sitting in the middle, we're working on the 2 side walls. So that's why it's considered a balanced decompression. The area in green and the area in blue are targeted. And the target is about a 6 millimeter reduction. And this is an example of a patient who had a 2-wall decompression. For more severe disease, we target the floor, which is the area shaded in red here. And then in really patients that we consider maximal decompression, so if your measurements on the reading that the ophthalmologist puts to measure the eye protrusion, if you're up about 28 to 30 millimeters, we perform what's called a maximal decompression, where we get the eye in as much as we can. There really is no further way to get the eye in. Every medical treatment has side effects. Medical in terms of medicine, medication, surgery. Some of the potential side effects that can happen with decompression have improved over the years we've been doing this operation. Diplopia or double vision is probably the most common side effect. It varies from surgeon to surgeon. It varies from the type of operation. Most of the time, if you're talking about general statistics, it happens about 15 to 20% of patients that have this operation. Numbness around the eye. We don't take the eye out when we do surgery. We work around it. Sometimes some of the nerves get tugged on. We don't cut the nerves, but sometimes when you're working, sometimes they get a little tugged on and there may be numbness. Usually that gets better. Sinus infection. We're opening up the eye cavity into the sinuses. Sometimes you can get infections. Vision problems are very rare. I know as patients you should be aware that there could be potential loss of vision. I, knock on wood, have not seen that happen in any of my patients, but it certainly has been described, and it's something you should be aware about. We can also perform in patients that don't need decompression. We do isolated lid retraction repair only. This is a patient who had upper eyelid retraction before and after. And again, here's another patient just showing the retracted eyelids before and after. Sometimes the lower eyelid can also be pulled down. This is an example of a patient who developed lower lid retraction. Sometimes this can be made slightly worse with extraocular muscle surgery. The lid may pull down, and sometimes we do have to repair that with grafts. So in summary, modern decompression is safe and effective. It must be tailored to the amount of proptosis or bulging that there is, and each patient needs to be individualized. At this time, we're going to switch gears of our session and move towards a panel discussion. I'm just going to share photos. Some of the photos that you see, just like Jerry showed, some of our patients have again, been very gracious in allowing us to look into their lives and feel what they go through. This is Barbara. She's a patient that's going to be on the second panel. This is her from when she was pre-disease. This is how she was prior to the onset of the eye disease. And you can just see over time, just gradually worsen to the point where she decided to do something. Barbara is, and with the panels, we decided to include patients at every phase of the disease. Some are completed, some are halfway through, some haven't even had their surgery yet. So you're going to get a perspective from many different perspectives. Barbara is about halfway through her treatment. This is her before surgery. Here she is after decompression only. She still will require eyelid surgery. This is another one of our panelists, Joyce. This is Joyce pre-disease. This is her at the height. Joyce is a performer. She's also was a teacher, and now she's able to participate in, this was the senior follies, I believe she said. She's a wonderful performer, and now she's able to resume her activities. Another panelist you're going to meet, this is Stephanie. This is Stephanie on her wedding day. This is when how she was when she came to see us. So I'd like to ask our first panelist to come forward and please have a seat. We're going to turn the lights on. We're going to shut the screen off, and then I'm going to turn the moderating of this portion over to Dr. David Granite. So we will